Hi, everybody, and welcome to a Prasiska GI Cancer-Focused Tumor Board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
So this is a 52-year-old male with a history of a clinical T3N1 distal esophageal cancer that was pre-treatment PD-L1 negative, received neoadjuvant chemoradiation followed by an Ivor-Lewis esophagectomy with a near path CR, and now presenting with a local recurrence in a mediastinal and left upper paratracheal node. And the question is, what are the board's considerations in management of this localized recurrence? So again, this is a patient presented with unintentional weight loss, appetite changes, and some epigastric discomfort. Performance status was preserved, and the patient was treated as we heard. The background is a factor V Leiden mutation with a history of DVT, reflux, and type 2 diabetes. Former smoker, 20-pack year, quitting 20 years ago, former heavy alcohol use, and a relatively benign family history. Again, here is the pre-treatment staging. I don't know if, Dr. Siegel, if you have any comments on these limited PET images that are shown.
I have a couple comments. So the upper image shows a very FDG-avid distal esophageal mass. The lower image, you can see the crosshairs on a very small but FDG-avid gastrohepatic lymph node that's suspicious.
Yeah, I agree. And so this patient, their story continued. In May of 2019, they had a repeat EGD with balloon dilation that was unfortunately complicated by a perforation requiring stent placement. This is prior to neoadjuvant chemoradiation, similar to our prior patient treated with cross regimen. Completed chemoradiation with some weight loss and esophagitis. Post-treatment imaging showed a partial response with a decreased uptake in the distal esophageal adenocarcinoma. And then about 3 months after completion of chemoradiation, the patient underwent an Ivor-Lewis transthoracic esophagectomy with, as was mentioned, a near pathologic CR, negative margins, and some pathologic downstaging with nodal clearance, now YP T3N1M0. Maybe I'll stop here and ask Dr. Weiser briefly to comment on the interval from radiation to surgery and what you think if there's an optimal time frame there.
Well, I think the feeling that the longer you wait, fibrosis sets in was always a concern early on. I think we've learned that the longer you wait, the more response you get. So you do have to find that happy medium between the two.
Definitely. So again, this patient was completed their curative intent neoadjuvant therapy, and then relatively early on in January of 2020 was undergoing imaging surveillance. And perhaps I'll let Dr. Siegel comment on the surveillance findings, which are noted by the, I guess, arrow sign there.
The image on the left is a coronal image, and there's a small caliper marking a left paratracheal lymph node that's enlarged. And you can also see the postoperative changes of the Ivor-Lewis esophagectomy and the stomach up higher above the hemidiaphragm. On the image on the right, you can see the a stomach, and adjacent to the stomach is a small, a low right paratracheal lymph node. And the lymph node on the left paratracheal lymph node is larger, and I think that was the one that was biopsied and was proven to be metastatic adenocarcinoma.
Exactly, yes. It was a EBUS approach with a left paratracheal node that was positive, as you mentioned. So the question from this provider is, what would be the recommendations for management of a localized recurrence? And maybe I'll start with Dr. Benson about, do you describe this as a salvage curable intent situation, or would you generally approach this thinking more palliatively?
Well, I think we need to stress that certainly people with esophagogastric cancers need to have their care at highly experienced centers where there's multidisciplinary team review. And so this is certainly a situation we would present at our weekly multidisciplinary GI oncology conference. And we would include the factors such as comorbidity, the patient's performance status, and for the surgical weigh-in, if this did appear to be potentially completely resectable with one more attempt as a curative approach. I think it's a very worrisome situation, and in some of these situations, by the way, we would also talk about any role for additional radiation. However, in this case, the patient had fairly standard radiation therapy, and perhaps that would not be favored, but rather should the patient just move forward with systemic treatment. So that's what we would talk about, but we would certainly want the surgeon's opinion about resectability, even though there would be concern given the relatively short interval that this is a patient perhaps who cannot be cured.
Yeah, I agree. I think the biology is definitely concerning in this case. And since we have a multidisciplinary tumor board, I guess I will put some of these questions to Dr. Patel and Dr. Weiser, and someone who's relatively close to completing a definitive course of radiation. Are there reirradiation options, and what kind of things do you need to see in terms of prior plan to determine that? And is this, I guess, proton world, since people often ask about that question?
Yeah, great question. This one's a little, I guess, a little hard to tell just from the few images we've seen. But a lower esophageal cancer treated with radiation, we typically extend the radiation field up maybe 4 to 5 centimeters above where the tumor is. So in this case, you might assume that that's sort of mid-chest. This level 2 paratracheal node above the aortic arch, to me, would be very likely maybe to be out of the radiation field from the prior treatment. So the first thing we would certainly want to do is to get that prior treatment, the records. These are the actual images of the radiation plans. And so this is something that my team would work directly with the place where the radiation is delivered. The paper records are not enough to make that type of a evaluation. And then we can overlay the old radiation doses onto a new scan and determine if the area in question has had prior radiation or not. Without seeing it, of course, I'm sort of guessing here, but I would guess in this case that maybe this node was not previously irradiated. It's possible that the anastomosis is even maybe below the level of this lymph node. Again, we're not seeing the axial image there. But all of these types of things, I think, are going to go into deciding whether, if radiation is doable, if it's going to be considered re-irradiation, which of course we want to be more careful about, or maybe in this case, a course of almost de novo radiation in this area. I think the short interval for recurrence is certainly concerning, and I agree with both of you about that. The fact, though, that we have maybe a lymph node along the chain that might have been outside the field makes me feel a little bit better about potentially offering radiation again. And if we did, and it wasn't previously irradiated, we could maybe go for even a higher dose than we might otherwise. Something similar to what we might consider for a lung cancer treatment, which would be very standard in this area to go to 60 gray, as opposed to more like 50 gray.
Yeah, I think those are all topics that we have in our own multidisciplinary tumor board come up a lot, and I think our team would approach it very similarly. Dr. Weiser, just for the listeners, what is or what would be a surgical options, if any, for something like this after a recent, esophagectomy?
Yeah, no, I do think there is a role for surgery in select cases, and there are studies that back this approach up. It is quite selective. I think this case has been well discussed. The short interval is a little bit disappointing. However, the tremendous response to treatment is quite encouraging. And I would agree that the patient's probably a very good candidate for radiation since they responded so nicely before. But I do think it's important to present it at a multidisciplinary conference. There are options for surgery here. I'm sure the lymphadenectomy did not extend to this level, and that could be removed surgically.
Yeah, I'll ask Dr. Benson one more question, which is, I don't think there's a lot of data to speak to this, but assuming the patient was a candidate for a second course of radiation, would you give them concurrent carboplatin, or would you think of FOLFOX or an alternate chemotherapy partner?
Well, because as mentioned, the patient, unlike our previous case, appeared to respond to the combination therapy. I do think it's reasonable to go back to the same regimen. Having said that, a regimen like FOLFOX would also be very appropriate in this setting. But
Yeah.
because it appeared that there was sensitivity to treatment, there was a pathological response, it's reasonable to go back. Certainly you want to know how well the patient tolerated the previous regimen, those kinds of things, but I would certainly consider that.
Totally agree. All right, that was a great case. Let's move on a little bit lower down the tube into a case of gastric cancer.
Can I make one last
So
comment,
this is
Dr. Klempner, about that last one?
Sure, yes, go ahead.
Just wanted to say, if we were going to irradiate in a situation like this, we do typically use small fields. So this is a lot different than what we might do from the first treatment. So what I would certainly want to have an endoscopy done to clear the mucosa, before we were to embark on something like this. The scans do not accurately, I think, give us an assessment of the mucosa itself and the anastomosis in the stomach. So that would be very important prior to considering re-irradiation, in my opinion.
Yeah, I agree. Our team also likes to know that there's healthy tissue that's going to be in the irradiation field as well, and totally endoscopy would be our practice